time, I welcome all the members of the IRA who is in this platform now, and I welcome the residents, and I also welcome our chairman of the academic session, Dr. Venu, who could not come today, and of course, Dr. Rijo, our secretary of Kerala IRA, who could not come. So in this platform, I'm welcoming all of you, and of course, our two special residents. Dr. Reshmi will be introducing them and introducing the faculty also. So I welcome all of them for the session today, which is going to be very great. So, and our delegates and the residents also. Thank you so much. Dr. Reshmi, over to you to the platform.
Thank you, ma'am. So welcome you all to once again to the academic session of Kerala IRI. We are continuing the gastrointestinal radiology academics this month also. So today we have PG case presentations from Karakoram Medical College, and we are lucky to actually have three faculties today. Jeena ma'am from Pushpagiri Medical College. She is the professor and head of Pushpagiri Medical College, and she has a lot of publications, and she's a known figure in almost all the conferences. She's a known guest lecturer in so many conferences, and her main areas of interest include body imaging and women's imaging. She's the journal reviewer of Journal of Gastrointestinal and Abdominal Radiology. She's a Riksha district coordinator for Pathanamthitta, and she's a faculty member of Crest Kochi and many other PG teaching programs. So welcome, Jeena ma'am. We are lucky to have you today here. And we also have Dr. Lali Madam. She is the head of department and professor Karakoram Medical College. As you all know, she's also a great teacher. Welcome, ma'am, to this. And also Neeta ma'am. She's a professor of radio diagnosis in Karakoram Medical College. Again, a very good teacher. Neeta ma'am, welcome here. So we have actually three cases today which are presented by the residents. We have three residents, Dr. Prabha, Dr. Binju, and Dr. Sai Kumar. So, ma'am, shall we directly go to the case now?
Yeah.
Oh, we'll start with the first case. I think Prabha,
all the three residents are from which college?
Karakoram Medical College.
Okay. Can I give a short introduction?
Sure.
Yeah, sure.
Good evening to all of you. Warm greetings from Department of Radio Diagnosis, Dr. SMCSA Medical College. At the outset, let me express our gratitude to IRA Kerala, headed by enthusiastic President, Dr. Gomadi Subramaniam, and ever-vibrant Secretary, Dr. Rijo Matthew, for opening this treasured platform to our postgraduate students. And a great fortune on this occasion is the very presence of two faculties. Resmi said only total three, but we have two faculties from outside our campus, very eminent teachers and diagnosticians. Dr. Jeena Benjamin, the professor and head of the department of Pushpagiri Medical College, and she is a very good diagnostician as well as the best medical radiology teacher who is training the postgraduate students. And I know a couple of her students who very thankfully and lovingly cherish the training they have received from Jeena during their postgraduate days. And about Resmi, and she's also our faculty for this day, and she's the gold medalist of National Board of Exam, very good diagnostician and a teacher, and also her talent, as you all know, extends beyond radiology. And I thank both these faculties who are joining us today to guide our postgraduate students this fine evening. Well, I have not seen anybody who is more enthusiastic than Dr. Reshmi, and I should agree. I should open up myself to tell that it is her enthusiasm that has dragged us to this platform this evening. With this, let me kick off the session. And we have three cases. First two cases are long cases, which will take 20 minutes each. And the last case is a short case, which will take 10 minutes. So we will try our level best to adhere to the time schedule. And the first case, the faculties who are guiding the students are Dr. Jeena Benjamin and myself, Lali Alex. And the PG who is unveiling the case is Dr. Prabha Joseph, a final year postgraduate student of Dr. SMCSA Medical College. Over to you, Prabha.
Okay, ma'am. I'll share the screen, ma'am, now.
Yes, you can share the screen.
Screen is visible, ma'am.
Yes.
Yeah.
Good evening, one and all. We'll go to our first case. It was a 21-year-old male presented with left hypochondrial pain since 1 month and increased frequency of bowel movement, that was 10 times per day, and reduced appetite and weight. The relevant lab investigations were HB was low, 7.8 milligram per deciliter, CRP was positive. We did an ultrasound for the patient. Patient had thickened and edematous splenic flexure, transverse colon, and proximal descending colon with adjacent hyperechogenic fat. We came to a conclusion of an neoplastic but infective etiology and proceeded with a plain and dual phase CT with negative oral and rectal contrast. This is the axial venous phase images showing a bowel wall thickening in the large bowel and in the small bowel. The images will be detailed in the following slides. So there is a homogeneously enhancing, that's gray pattern, asymmetrical circumferential long segment wall thickening for approximately 6 to 13 mm involving the mid and distal transverse colon, splenic flexure, and proximal descending colon. There is significant luminal narrowing with no proximal dilatation. This is the long segment wall thickening of approximately 25 centimeters long with significant luminal narrowing and no proximal dilatation. There were multiple pedunculated enhancing polyps in the mid-descending colon. There was focal non-enhancing area in the splenic flexure with adjacent poorly marginated fluid and extraluminal air. As seen here, there was diffuse pericolonic fat stranding with few discrete sub-centimeter non-necrotic lymph nodes. After seeing the wall non-enhancing area, we gave a positive rectal contrast, but however, leak could not be demonstrated. Coming to the rectum, there was a diffuse wall thickening with minimal mesorectal fat stranding. Adjacent, there is a focal peripherally enhancing collection in the right ischiorectal fossa adjacent to the pubococcygeus muscle. And on the left, you can see a perianal fistula with external opening at 5 o'clock position. These are the findings in the large bowel. Coming to the small bowel, there is multiple short segment asymmetrical wall thickening in the ileum with shortening of the mesenteric and saculations of the anti-mesenteric border. There is a mesenteric fat proliferation with prominent vasa recta. That was the Coombs sign was present. The cecum and IC junction was normal in position. Cecum was not pulled up. The IC junction valve was angle was normal. There was on the vessels. The portal vein was normal. There was no thrombus. The mesenteric vessels were normal. There was normal in caliber with no filling defects were seen. Coming to the organs, in the liver, there was focal fatty infiltration. The rest of the solid organ, spleen was normal. Kidneys, there was no nephrolithiasis. GB, there was no gallstones. In the bones, there was no evidence of sacroiliitis. So coming to the summary of the case, it was a 21-year-old male presented with left hypochondrial pain. There is a segmental, homogeneously enhancing transmural colonic and rectal involvement with multiple skip lesions in the ileum with associated contained perforation, ischiorectal abscess, perianal fistula, and multiple sub-centimeter enhancing lymph nodes. We came to the diagnosis of an inflammatory bowel disease, that was Crohn's disease.
Dr. Prabha, that was a very good and very clear presentation of the, you have described all the findings in detail. This case will be handled like the madam said, a part of it, the initial aspect of the conventional aspect, the barium and ultrasound aspect will be dealt with by me. I will be questioning her on that. And followed by the mainstay of the diagnosis, that's the cross-sectional imaging, will be dealt with by question by Lali madam. Yeah, so Prabha, you have given only a single diagnosis. I just want you to just highlight the the salient features based on which you gave this single diagnosis of Crohn's disease?
In this case, there was transmural colonic involvement, including the rectum, and there were multiple skip lesions in the ileum with complications like ischiorectal abscess, perianal fistula, and also a contained perforation. So I thought Crohn's disease as a single diagnosis, and there was no differential for that one.
Okay, yeah, so you have very rightly just stuck to certain, there are very few conditions when you can really pinpoint, but in your case, I mean, there were so many findings which makes another diagnosis rather impossible. So you have, it's very much justified that you have given a one single diagnosis. Okay, so you have shown basically the cross-sectional imaging, that is a CT and angiographic images for this particular case. I just want to know, suppose you had a scanogram, suppose you had an X-ray, this patient was brought to you for a suspected case of inflammatory bowel disease. What are the points that you will be looking at? I'm not saying you can make a diagnosis from it, but basically, what are things that will be in your mind and the things that you're going to look for?
Okay. Now, in a case of Crohn's disease, the patient can present with small bowel obstructions. So you can see whether the dilated small bowel loops can be looked for. Any abscesses can be seen as air fluid levels. Any perforation can be assessed if it's perforated, like gas under the diaphragm. Then extraintestinal manifestations like sacroileitis. Then any nephrolithiasis, gallstones, and all can be assessed in the next.
So you said the bowel loops may be distended. So once they are distended with air, suppose they do have a lot predominant in supine radiograph, especially when you have more of air filling up the loops. Will it be possible to even in a very advanced case, would you be able to make out some changes as well in the walls? Because the lumen is filled with air.
Filled with air, it's like dilated toxic bag. What you mean?
No, you can even look at the way the valvular coniment is.
Valvular condiments, whether thickened or.
Yeah, because to a certain extent, it's very, you can even make out that the valvular coniment is either distorted or is thickened, right? Yeah. Yes, and when there's significant the wall thickening, you can see even the displacement of between the loops of bowel, right? Yes, which makes you think that there should be some amount of wall thickening. So yes. Nowadays, when in any suspected case, mostly people order an MR or a CT angiography, but there are sometimes you may have to do a barium study. So when do you think you may be required to do barium study?
Barium study, maybe early presentation for looking for an aphthous ulcer.
Yeah, early features, yes, I mean, much better brought out this. I mean, if you are not able to do a scopy, of course, then the other modality would be barium study, right? And yes. You would be able to make out the early features better. So those features are?
Any aphthous ulcers.
Yeah, how does aphthous ulcer look in a barium?
There will be pooling of barium, that's superficial ulcer. There will be pooling of barium with surrounding edema.
Yeah, it's like a bullseye, right?
Bullseye.
Yeah. Okay. So those are one of the things. But aphthous ulcers, can you get multiple conditions, right? Okay. What else?
Yes. Then deep ulcers like Roston ulcers or stellate ulcers.
More advanced, yes. When it's more advanced, you will get
Roston ulcers.
Yes.
Then the interlacing of the ulcers can get a cobblestone appearance.
Right.
Then cobblestone appearance you can see. Then strictures you can see.
So before you go on to such extensive ulceration with cobblestoning, the initial ulcers would be what type and along which border?
In the mesenteric border, linear ulcers.
Yeah, this is if you can catch those linear ulcers along the mesenteric border in the initial aspect, that is quite almost clinching the diagnosis, because you don't get that kind of ulcers in even ulcerative colitis or in TB, right? Yeah.
Yes,
so right. So that is one of the features which is well brought out in the double contrast in the barium study, right? Yes, then So what else? The
Uh,
rose thorny you said, yes.
Then any creeping fat, there'll be
That is,
shortening of the mesenteric and circulation, so the anti-mesenteric border
yes,
can be.
yes, which can very well be seen and brought out in the CT and MR as well,
Yes,
right? But that is very well seen, right? Then even the complications can be very well brought out, isn't
yes,
it?
fistulas
Right.
can be made out.
Yeah, enterocolic
Enteric.
fistulas, yes, they
Fistulas.
can brought out. What is the sign that is seen when you have this enteric fistulas and all that? What kind of sign? What sign do you call that? When you have the fistulization of the bowel, I mean, like even in MR, there is a term. What's that? The star sign, right? Because they clump together, they come to a point. Okay,
Yes.
so when you have a penetrating kind of complications, where do you look for? You have a Crohn's advanced Crohn's, then you have a dilated segment, you have a structural segment. So you'll be more worried about complications happening in which segment? The dilated part, the narrowed part, the structural area. So which is the area that gives from where the fistulas and the abscesses and the sinuses, they develop?
From the dilated.
No, it is from the strictures. Okay, so even in a CT, when you see any complications that happen, it's very, very unlikely that these penetrating kind of disease happens from the normal segment or from the dilated segment. It is when you have a structural segment, it's usually the active structural segment, and from there that you have all kinds of penetrating. This is the same thing when you do the barium. Also, you have to look for the structural segment. When you have the structural segment, you have to look for the other associated complications. You have any sinuses, fistulae, or anything. That's the same thing you do in your cross-sectional imaging as well, right? And so when do you do this? When you have a chronic kidney disease patient, you may have no option to do MR or CT angiography, and you may have to resort. The only thing that you have in front of you may be the barium study. Okay, does ultrasound help? Same thing, like when you have to in a CKD patient, or when you have to follow up a patient, you can resort to ultrasound as well.
Pregnant patients, you can see the wall thickening.
Yes.
Wall thickening can be assessed. Then in a hyperemia, like in Dopplers, you can see.
You can do Doppler, yes, you can do, yes, and you can make out the creeping fat sign. How will it appear in Doppler? The surrounding mesentery, how will it look? Very hyperemic and thickened. Right.
Hyperemic and thickened.
Yes.
There will be no peristalsis or decreased or absent peristalsis.
Yes, that peristalsis, and whether it's propulsive or non-propulsive, whether it is expanding when the wave of peristalsis comes. If it is that can be very well seen, because in barium also there's advantage. You have to watch for the peristaltic wave, and if it opens up during the peristalsis, that means it is not a really fibrostenotic, it's only a spasm. Whereas it's right, if it's always narrowed, even when the peristalsis comes, it's actually a fibrostenosis, not spasm. Okay. So yeah, so these things can be made out not in CT or MR. This can be made out in ultrasound and in barium, because you are seeing it dynamically, right?
Yes.
Okay. And you can also assess complications. If you're using a graded compression technique, you may even be able to see the complications like fistulization, connection between two bowels. Yes. And the abscess can also be seen, right?
Yes,
so so you have to know that all these things can be, to a certain extent, can be seen, right? Okay, so if you're going in for a CT and MR, what is your basic idea? If you have already done an ultrasound or a barium, you've seen this, what is your idea? What more are you going to see in MR and CT, which is going to be explained? Ma'am is going to question you on. What's your idea when you go ahead with the CT and MR? Is it to see the mucosal lesions better?
No, transmural involvement, luminal lesions.
I think I will hand it over to Lali Madam now to carry over the rest of the.
Thank you, Gina.
Thank you.
Am I audible?
Yes,
yeah.
Yes, ma'am.
Indeed, it was a very good illustration of the imaging findings. Only thing is that I'm not very happy with the final impression, which we will discuss in course of time. Well, in this young patient with bowel involvement, I think he was hardly 21-year-old. Why you have selected CT contrast instead of going in for MR enterography?
It was an first initial modality, ma'am. Initial investigation, and to rule out other causes also CT was helpful. Patient, we didn't know it was Crohn's, but we initially thought of as a lymphoma. To from diaphragm to symphysis pupils to be covered, ma'am. So, and to check, eliminate the other differentials, we went in for a CT, ma'am.
Yeah, because there are many other conditions which can have similar clinical presentation. And also, was your patient ill?
At the time of presentation, patient was not acutely ill. Patient had abdominal pain, but not acutely ill.
So it is because you wanted to rule out other possibilities and have this is the first study. So you would like to have CT contrast study for this particular patient. Can you just tell the protocol you used for this patient?
For this patient,
very briefly.
Okay, ma'am. The patient was given oral contrast with oral mannitol with plain water with total of 1.5 liters over a period of 40 minutes. And IV
what is the percentage of mannitol which you used?
2%, 20%, 2% mannitol. Yeah. Then over a period of 40 minutes, and IV contrast of IOXR 350 milligram. Then rectal contrast was water, ma'am.
Yeah. So for the IV contrast, the phases, what are the phases which you have selected?
For this patient, a late arterial.
Ideally, what should you be doing?
Ideally, it should be enteric phase and enteric phase and venous phase.
What is enteric phase?
Enteric phase is a late arterial phase.
Yeah. It's a late arterial phase. Why is it called a late arterial? Why you selected this late arterial phase?
Bubble wall enhances uniformly in a late arterial phase.
Yeah, mucosal enhancement is best seen in the late arterial phase. Well, you have done a study with negative contrast, negative oral contrast. Yes, okay. So why you have selected a negative than a initially you have taken up a negative contrast? Why you have taken up a negative contrast?
Mucosal lesions are better delineated in a negative contrast.
And also mucosal enhancement is better.
Enhancement is also better seen in a negative contrast.
Yeah. Another thing is that you used mannitol, no? Which was a negative contrast agent, which can throw water into the bowel and you can get a optimal
better distension of the bowel wall can be.
That is also another advantage of it. What are the other negative agents which you could suggest other than mannitol?
Water, polyethylene glycol,
very good.
Ethyl cellulose.
Yeah, okay, very fine. In between, you have gone in for positive contrast. You have also given positive contrast for this patient?
Yes,
in between.
Rectal contrast.
Why you have given positive oral contrast?
Rectal contrast was given.
Yeah.
There was a wall disruption in the splenic flexure to identify, to check for the leak or fistula. To identify the leak, we gave a positive rectal contrast.
Yeah. Is there any other use for this positive application for positive contrast in a setting like this? In a setting, a scenario like your case? Can they have abscess?
Yes, ma'am. To delineate whether it's an abscess or into the abscess, there will be contrast leak to identify the abscess, or can differentiate from the bowel.
Pardon? Interloop collections will be better delineated when you have given a positive oral contrast. Well,
yes,
as Dina also has correctly pointed out, you are made even a single diagnosis. I think you are very, very confident. But suppose I pose a question, can it be tuberculosis, intestinal tuberculosis? how do you defend?
Usually the site of involvement of abdominal TB is IC junction. Here IC junction was normal in position and the wall angle was maintained. There were sub-centimeter enhancing lymph nodes. In abdominal TB, there will be large necrotic lymph nodes. And the complications like fistula, perforation are all less likely in a tuberculosis. Coombs sign will be absent. Multiple skip lesions won't be there in tuberculosis.
If I may just interrupt, Lali ma'am, just want to ask her one thing. Yeah, what about the cecum involvement? Will that help you in differentiating?
Cecum involvement in this patient, cecum was not involved. Usually, the abdominal TB involves IC junction and cecum.
What is the pattern of involvement of cecum?
Cecum will be contracted, conical cecum and pulled up cecum.
Yeah, right. You have to. You said only the ileocecal junction, and that's the only aspect you said. Then you went on to lymph nodes and also in the bowel itself, the pattern of involvement itself. There are many differences, right?
Yes, ma'am.
Yeah, so you have to specify all those differences. Then only you go on to the lymph nodes and the complications and all that. So there are various differences in the pattern of involvement itself, TB versus Crohn's, right?
Yes, ma'am.
I think that's what ma'am was asking.
Okay. Cecum was not pulled up and it was normal in position, and the shape of the cecum was not conical. IC junction was normal and valve angle was maintained.
There's also eccentric versus concentric strictures, right?
Yes, ma'am. In TB, there will be concentric involvement and the pictures will be transverse. And Crohn's, it is usually longitudinal, asymmetrical wall thickening with shortening of the mesenteric and circulation of the antemesenteric.
Okay. Ma'am, sorry, ma'am. Carry on, ma'am.
Prabha, can you hear me?
Yes, ma'am.
I think you have discussed about there is some procession going on the road. So I think you have discussed about tuberculosis, ulcerative
Yes,
colitis too. Yes?
No, ma'am.
So
no, ma'am,
suppose
not
I tell it is ulcerative colitis. So I pose a question whether can it be ulcerative colitis?
Okay, in ulcerative colitis, it is a continuous involvement of the bowel. Here it is discontinuous and multiple skip lesions are present, and it is transmural involvement in this case. In ulcerative colitis, it is mucosal involvement, and the mural stratification will be preserved.
Well, what about ischemic colitis? Ischemic colitis.
In ischemic colitis, here rectum involvement is present. I mean, ischemic colitis, usually the rectum will be paired. No?
That is in case of occlusive type of ischemic colitis. But you see, in non-occlusive type of ischemia, rectum can also be involved. But in your particular patient, when, both these types usually occur in patients over 60 years of age, right?
Yes, ma'am.
But your patient is very young. Could it be vasculitis, which can present similar to Crohn's?
There is no thrombus in the vessels, ma'am. Vessels were normal. There was no filling defect. And the caliber was normal. There was no aneurysms.
So when do you suspect vasculitis as a cause for bowel pathology? So when you have unusual sites of involvement, like when gastric involvement is there, duodenal involvement is there, when rectal involvement is there, and practically the duodenal involvement is very suggestive of vasculitis. And also you will see changes in the vascular structures. You may see narrowing, you may see aneurysms, and also you have to look at the other solid organs and tell whether there are any infarctions. And also you have to give your ear unto the symptomatology of the patient. So you have to correlate with all these things to come to a final diagnosis of vasculitis. So vasculitis is one of the things which can closely mimic the Crohn's disease. Well, when you showed this case, there was an area of excessive thickness in the left colon, which was maybe more than 10 or 15 mm. What is your comment on that?
Usually Crohn's disease patients have wall thickenings of 1.5 centimeter, but an underlying lymphoma can be suspected in patients with Crohn's disease.
So these are the two possibilities. They can go in for lymphoma or carcinoma. So they usually go in for these symptoms after say 5 to 7 years of illness. Well, when you have given your presentation was very good, but finally when you have given your report, you have just written Crohn's disease. So would you want to add on anything? What are the, as a clinician, what are the things they want?
It is an acute on chronic Crohn's, ma'am, because of the presence of abscess, rectal abscess.
Yeah.
There is perienteric changes. Yeah. And at the site of perforation.
So you have to write that. You have to write whether it is active disease.
Yes, ma'am.
Is it important?
Yes, ma'am.
So your report lacked that, whether the disease is active, and whether what are the other things your report should be a structured report.
Yes,
other than describing your findings, you have described your the bowel findings, you have said your mesenteric findings, and but finally you have not said it is whether there was any extra intestinal complications.
Yes.
Was there any extra intestinal complications?
Yes, ma'am. There was a contained perforation, then left perianal fistula, and right ischiorectal abscess. So there was fatty liver in the.
Yeah, that was the only thing. And you should also tell whether it was an active disease. Well, yes, what was the, is there any indication for going in for MRI in this case, in your case?
Yes, patient can be followed up with a MR enterography, ma'am. Yeah. And because of the soft tissue contrast will be better in MR enterography.
Your patient was also having perianal
fistula.
Yeah.
Complications like perianal fistula can be better identified in a MR enterography.
Yeah. What are the additional? What is the role of MRI? You said one is for follow-up of the patient, right?
Yes, ma'am.
Yeah. Then how do it going to help MRI? What are the things which are which you can gather out of MRI in this particular patient or MRI, any patient with Crohn's?
MRI, we can grade the Crohn's in MRI.
Yeah, it can grade the disease. And your patient falls into which grade?
Falls into a severe grade, ma'am, because of the presence of complications.
Okay, so you can grade it. Then
for follow-up and for follow-up for young individuals, can go.
Can you assess the activity?
Yes, ma'am.
Can you tell whether it is active or not by looking at the MRI?
Yes, ma'am.
How do you tell it?
In presence of enhancement.
Yeah. Then
perienteric changes.
Perienteric changes.
Then any abscesses.
Yeah. Yeah. Okay.
Then
can you use diffusion to find
diffusion,
out whether
yes,
it is
diffusion restriction. If diffusion restriction is present, it is an active disease.
Okay. So you said it is better followed up. The cases of Crohn's are better followed up by MRI in view of the radiation disk. Is there any instance? Suppose your patient is having some contraindication for MRI. How do you plan to follow up this patient?
Ultrasound can be done.
Yeah, one is ultrasound can be done to follow up.
Then barium can be done for follow up.
It does not. So can you use a low dose CT protocol?
Yeah, low dose CT can be done for follow up if it's MRI.
Yeah. How do you attain a low dose? CT?
Reducing the KVP.
Yeah, you can reduce the KVP. Can you use an automatic exposure control?
Yes, ma'am.
Yes. And also you can reduce the area and select the, you can tailor your area of interest also when you select the scanner. Well, other than making a diagnosis, does radiologists have any role in the decision making, management decision making in case of Crohn? Yes.
If it is we can
Yes.
say whether it's active or inactive TB, inactive Crohn's.
Yeah.
Then
Active, they have to go in
pictures,
for medical treatment.
medical treatment.
Then
If it is any complications are present, we can be told.
in a case of stricture, how are you going to help them?
If there is stricture, then they can go in for surgical management.
Do all strictures go in for surgical management?
Causing complications like small bowel obstructions.
No. Can you tell whether it is the stricture is due to inflammation or due to fibrosis? Can you tell when you image it? Can you tell?
Yes, ma'am. Asymmetrical thickening.
By various MR sequence, you can tell whether your stenosis is fibrotic or not.
Yes,
so,
T1 and T2
if the stricture is due to inflammation, you can go in for medical treatment. Whereas if it is due to fibrotic, you can go for surgical management. Then, what about abscess? Does radiologist have any role?
Abscesses, we can drain the abscess pigtail insertion.
Will you drain all the abscesses? No, the indication to drain the abscess is when when there is concern for sepsis, and also when when your collection is very large. Okay. Then what else you can give? What other way you can be part of the management team? Can you tell them about the extra-intestinal complications?
Yes, ma'am.
Yes.
Yes.
Then can you give suggestions to follow up this patient?
Yeah,
because these patients are more prone to develop lymphoma or bowel malignancies. So they can also advise them the direction in which these patients has to be followed up. So I think we have to wind up here. Before winding up, can you very quickly give your approach in a patient who is having bowel wall thickening? Very briefly, you can tell.
Bowel wall thickening can be classified into 4, like focal, that's ultra short, less than 5 centimeters.
No, you want to look at whether it is
length of involvement.
Length of involvement, very good.
Length of involvement, if it is less than 5 centimeters, it's more in favor of malignancy.
Yeah.
If it's ultra short, then if it's 5 to 10 centimeter, that's also focal. It can be of infective, like diverticulitis.
Okay. So the message you have given is, if it is very short, you have to be the possibility ultra short.
Ultra short, possibility of malignancy.
Malignancy, and if it is diffuse involvement,
it can be infective.
Okay, so you can relax when the involvement is diffuse. Then next point is
next is segmental involvement. That is
you have finished the length of involvement. So that is first thing.
Pattern of involvement.
Pattern of involvement. You can
white,
tell the main points.
If it is a white pattern of involvement, it can be in favor of an acute IBD, then or ischemia. Then it is gray pattern of enhancement is present. It can be a chronic IBD. Then if it is stratified, also it can be in an inspection or an ischemia.
Okay, so you look at the pattern. Will you look at the degree of mural thickening?
Yes, ma'am.
Okay.
If more than 2 centimeter, then and long segmental, chance for lymphoma.
Okay, then after the bowel, you go into the look at the perienteric changes.
Perienteric changes. Then if it is more fat stranding and less wall thickening. It's more in favor of a infective etiology like omental infarction or epiploic appendicitis.
Okay. So then finally, you have to also look at the vessels. Mesenteric vessels also has to be looked into.
Yes.
And also the solid organs. And one thing which you haven't left out was whether you should also comment whether there is associated ascites or not. So these are the main points you have to look into when a patient comes with bowel wall thickening. I think with that, we will wind up the case. I think you have done very well in your session. Other than you have to just modify your pattern of your reporting, final pattern, your summary, the way you have given it. It should be done in such a way that it would give a comprehensive idea about the patient. Thank you.
Yes. Okay.
Madam, there are some questions in the Q&A box. Was mural stratification seen in this?
Mural stratification was lost. Huh? You couldn't differentiate the
It
layers.
was homogeneous enhancement, right?
It was mucosal.
It was homogeneous enhancement, right?
Homogeneous enhancement.
What is the ileocecal angle in TB and in Crohn's?
Ileocecal angle will be acute in Crohn's and it will be patulous and widened in TB.
Yeah, because of the fibrosis. And one question was whether by enhancement pattern can you differentiate TB and Crohn's?
In TB, it will be acute Crohn's, it will be white pattern of enhancement, and chronic Crohn's, it can be a gray pattern of enhancement. Usually, TB will be gray pattern of enhancement.
You see, stratification is more in favor of Crohn's disease. Sometimes we don't see stratification. Sometimes we also see that homogeneous enhancement similar to TB. So that's not. If you see stratification, more in favor of Crohn's. That's it.
Yes.
Okay. Ma'am, shall we? It was an excellent discussion by both Jina ma'am and Lali ma'am. Thank you so much. Madam, shall we move to the next case? Or?
Yeah. Next case, I think the next case, the faculty for the session shall be Dr. Rashmi and Dr. Nita, and the case will be presented by Dr. Vinchu Michael, our exam going student.
Good evening all. Next case is a 58-year-old female patient presented with complaints of intermittent abdominal pain for 3 months with an acute exacerbation localized to the left hypochondrium since 4 days. The past history of there was a past history of hospital administration with lethargy and low SP, for which she had 2 units of blood transfusion. She was non-case of diabetes mellitus for 10 years. And on this admission, her HP was 6 milligram per deciliter. Total count was 13,000. CRP was elevated. And she was referred to our department for ultrasound abdomen. On USG abdomen, in spleen, there was a well-defined cystic lesion with rupture into the hilum, and the lesion is showing internal echoes and peripheral vascularity. There was minimal left pleural effusion seen adjacent. There was no ascites, no lymphadenopathy. Rest of the solid organs appears normal, no bowel dilatation. And we gave the diagnosis as ruptured splenic abscess, possibly pyogenic. She was further evaluated with CECT abdomen. The protocol was oral contrast neutral was given 2% mannitol over 45 to 60 minutes. Rectal contrast was plain water, and IV contrast 100 ml of iohexol given at the rate of 3 to 4 ml per second. And phases taken was plain and triple phase, that is late arterial, portal, and venous phase. Coming to the CT abdomen. There is a well-defined, non-enhancing central hypodense irregular walled splenic lesion measuring approximately 7 into 5 into 4 centimeter, extending anteriorly via gastrosplenic ligament, indenting into the posterior wall of stomach, up to submucosa with a normal mucosal enhancement and focal gastric wall thickening of approximately 15 mm. Posteriorly, the lesion is extending into the subdiaphragmatic area, subdiaphragmatic space with adjacent left pleural effusion. And in the lesion, there was no calcification, hemorrhage, or air foci. There was few small lymph nodes was noted in the paraesophageal and lesser omentum, and also noted in the porta hepatis and in upper paraesophageal region. Rest of the small bowels and large bowels were unremarkable. Pancreas was normally enhancement with no focal lesions or signs of pancreatitis. Rest of the visualized all organs like liver, kidney were normal and no focal lesions were seen. And in view of indenting into the posterior wall of stomach, we gave positive oral contrast to look for any communication with the gastric lumen. In positive contrast, we could see a smooth lobulated lesion indenting into the lumen of stomach, forming an right angle with the anterior wall and an acute angle with the posterior wall. With all this findings, we gave the first differential is ruptured splenic abscess with indentation into the posterior wall of stomach and subdiaphragmatic space with left pleural effusion. So that is ruptured splenic abscess, ma'am, likely pyogenic.
Vinshu, let me stop you there before you go to the MRI. Yeah, it was a crisp presentation, but let me ask you a few things that you had missed out. What was the size of the spleen? Was it normal or was it enlarged?
So the size of the spleen was normal, and it was about 10 centimeter, ma'am, craniocaudal.
Okay, so then we'll come to CT. We'll start with ultrasound. In ultrasound, how did you differentiate this? How did you go about this lesion? What are the things? Basically, splenic lesions are not common. That is the reason that we really have this case, because very rarely do we come across splenic lesions. So how do you approach a lesion in the spleen? So that's my first question. We'll go to CT next. How do you approach a lesion in the spleen?
The spleen, first we have to look for the if it is cystic, mixed solid cystic, or pardon, ma'am?
Yeah, correct. Cyst or cystic and solid, or
solid lesion. Very
good. So that is your main thing. So in this ultrasound, you were very sure because of the it is very hyperopic. There are few moving internal particles, so you're very sure it is a cystic lesion. So we will keep the cystic and the solid lesions away, and then we will deal with cystic lesions. Okay, can you tell me what are the cystic lesions that may be seen in a spleen?
In spleen, first one is a simple, most common is a true splenic cyst. Next is the secondary cyst like pseudocyst, that is post-traumatic pseudocyst, post-infection pseudocyst, and intrasplenic pancreatic pseudocyst. Then infections like abscess and splenic hydatidis. Then other lesions are splenic hemangioma, lymphangioma, then splenic lymphoma.
There are very different ways to classify it, like congenital traumatic. One simple way is to say parasitic and non-parasitic. Okay, and then you also have cystic neoplasms, and all the other complications will come to. In the non-parasitic cysts, we can easily classify them into true cyst and
secondary pseudocyst.
Okay, so because there are a lot of differences between these two, and then now all of them can go into further complications. So there is another subset, that is the infection. Not only the parasitic, you have non-parasitic infections, including fungal, tuberculous, and pyogenic. They're all very uncommon. So the number of lesions also make a difference. So now we have a cystic lesion, which is solitary. If I tell you true and pseudocyst, which is more common?
True cyst, most common is a true cyst. Simple cyst is the most common.
Pseudocyst, out of 5 cysts, pseudocysts are 4 out of 4 is to 1. Almost 80% of the cysts are pseudocysts. And then age-wise, can you decide true cyst, pseudocyst? True cyst, can you say differentials of true cyst, right? What are they? Can be a simple cyst.
Okay. Pseudocyst, ma'am. It can be post-traumatic, post-infection, and intrasplenic pancreatic cirrhosis.
Or it can, okay. So they are all generally happen in an older age group, right?
Yes, ma'am.
True cyst can be?
Simple cyst in the younger age group.
Yeah, epidermoids. You can have peritoneal, mesothelial cysts. They're all examples for your true cysts. Okay, so all these cysts can further undergo complications like you mentioned. Do you think this could have been a hemorrhage? Hemorrhage into what? Why did you say infection?
There was no history of any trauma. Then the vascular supply of the hilum spleen was maintained. Then in CT, there was in plain CT, there was no hyperintensity areas or hemorrhages.
No, yeah, we'll go to CT. At ultrasound level, maybe HP was very low. Maybe a hemorrhage, unknown. No, that trauma need not have been documented. She might not have realized. It is possible, but the spleen size was normal. Okay. So now coming to CT. How do you assess the size of spleen on CT?
It can be assessed in
size in an adult generally.
Normally in craniocaudal it should be less than 15, and
CT exactly. Yeah, if you take a perfect, it should be less than 15. Okay, 15. Okay.
Then AP less than 6, and then
on an axial scan, the transverse
diameter will be less than 6 centimeters.
10. Perpendicular to that will be 6. The transverse diameter in an axial scan, easily to measure, will be 10. So 6, 10, and 15. Okay, what is the CT protocol that is suggested for splenic lesions?
It was the triple phase CT, then late arterial, then portal and venous phase. Then
the ideal phase for splenic lesions?
Ideally is the portovenous phase.
Why?
Because in arterial phase there will be differential enhancement of the spleen due to white and red pulp. Then in portal phase there will be homogeneous enhancement of the spleen. So it will be very.
What additional good? That's your protocol. So ideally it's a portovenous phase. What are the additional information that you obtained on CT that we did not get on ultrasound? Start with the splenic lesion. We will concentrate on the splenic lesion, and then Dr. Reshmi will continue with the final conclusion.
Okay. Yeah. In CT, we could say it is a main. We can see the extension of the lesion into the posterior wall of the stomach, and the main lesion was within the spleen, and
calcification.
There was no calcification, air foci or hemorrhages. Noted.
Okay. The plain CT did not show high density, I presume. There's no debris. So, okay, you are better in analyzing all that. What are the features? We'll talk just about the splenic lesion, not the rupture. What are the characteristics that would tell you that this could be a cystic neoplasm?
There is no in thick wall, irregular wall, then enhancing wall, then solid areas,
enhancing wall, okay, solid component,
then nodular.
Does calcification tell you whether it is malignant?
No, ma'am.
Calcification, where all are calcification seen?
Calcification seen in simple cyst can be seen, then hydatid cyst, then
Also pseudocyst. Pseudocyst can also have calcification. That doesn't really help us. What is a giant cyst? When do you call a splenic cyst? So let us assume that this is a cyst. Let us assume that it does not have any features of a malignant neoplasm. So we will assume it's a benign cyst, right? So what are the what is the size criteria for a giant splenic cyst?
more than 10,
15.
Yes,
15. Okay. Now, in a cyst, what is the criteria? Like we have to tell the surgeon, okay, now you're saying that we do not see any malignant features. In a benign cyst, because of the complications of hemorrhage and rupture and all that, what are the criteria that a surgeon may make the surgeon want to do a splenectomy? Do you know the criteria that may make the surgeon want to do a splenectomy on the case?
If the lesion is extension of the lesion and
Very
rupture,
large, very large lesion.
very large lesion.
Yeah, there's hardly any normal splenic tissue. Okay? Less than 25% splenic tissue may warrant a splenectomy anyway, whether or not it's benign or malignant. One. Another one, site, location-wise, extension into the hilum. So like this lesion is not so big, but it is extending into the hilum. So that's another thing that may suggest the possibility that this may go in for a splenectomy. Do you know of any current treatment, radiological intervention that you can do avoiding a splenectomy, especially in a patient like this?
In aspiration, as CT aspiration can be done in large lesion.
Possibilities for benign cystic lesions without directly going for a splenectomy, which was done earlier. Okay. I think, would you like to do any more evaluation for this patient? Because what are your doubts or what are the loose ends at the end of this CT? Is it important to see the vessels in this case?
Yes, ma'am.
I don't think you commented on the vessels. I don't think you commented on the splenic artery or the vein or the major vessels. Is it important?
Yes, ma'am. To look for any lesion for any thrombosis or disruption of the splenic vessels and
infarct, right? Infarct is something which can hemorrhage, so we can explain the low HP. And then infarcts can go into secondary infection also. Do you have any doubts about the localization of the lesion? Do you think this is primarily a splenic lesion? Or do you think that this could be an extra splenic pathology extending into the spleen? What are your points for assuming this is a splenic lesion?
Because the major part of the lesion, the center of the lesion seems to be in the spleen, and also there was an extension of lesion.
No. But can you see any sign? Can you say any specific sign?
Embedded organ sign can be visualized, and the spleen can be seen. The lesion is seen within the organ with the surrounding normal organ tissue. That is embedded organ side. Then other points are the extension of lesion to the subdiaphragmatic area space with the adjacent pleural effusion. There was minimal peri-hilar fat stranding also.
Would MRI help you in this case? Once you do the MRI, once you present the MRI findings, Dr. Reshmi can take over. Yeah, continue.
Yeah, okay. Yeah, before going to the MRI, one suggestion is that whenever you show a case like this, always show the plain CT first. Because in such a case, that's very important, because one of the most common lesions in spleen is what? In our common clinical practice, what do you get? It's such a similar lesion. It's a hematoma. We often say hematoma, splenic hematoma, so which will be hyper on CT. So as spectators, like we want to first know the appearance in plain CT. So next time also when you present, you always show the plain CT and then go to the contrast. And you were telling that it was a non-enhancing lesion, correct? When you described the
Yes, ma'am.
but I have some doubt seeing the CT here. Some see the periphery, it has different attenuation, correct? The center is more hypo, and in the periphery, it's little hyperdense compared to the splenic parenchyma, right?
Yes, ma'am.
Especially in the sagittal view, you see different densities, right? Do you
Yes,
see
ma'am.
that? So see how can you describe that once more? Is it enhancement or is it a debris? Did you compare it with the plane, that peripheral?
Yes. Peripheral, actually, it was not enhancing, ma'am.
Even it was little hyperdense on plane?
No, ma'am. Actually, it was plain. It was not enhancing, actually. It was same as.
You checked the CT attenuation in plane as well as in contrast?
Yes, ma'am.
Okay, so you're sure that even the periphery of that
Periphery
lesion
of
is
the
not
lesion.
enhancing? It's a
Not.
completely non-enhancing lesion, correct?
Yes, ma'am.
So what is the importance of that?
To look for any wall of the lesion, capsule of the lesion, or thick walled or thick irregular walled lesions.
Yeah, so it's basically an irregular lesion, correct? It's
Yes,
not, we can't just tell us as a simple cyst. It doesn't have the attenuation of a simple cyst in CT, right?
Yes, ma'am.
In ultrasound, you can tell because it's just that moving internal echoes, but the margin of the lesion is completely irregular. So
Yes,
when
ma'am.
you see such an irregular lesion, the one thing, like, what is the age of the patient?
A 58-year-old, ma'am.
58-year-old. You should always think of the possibility of what?
Malignancy, secondary cystic regeneration of the malignant lesions.
Yeah, any malignant lesion, you should always think of, because in any elderly patient, plus this patient doesn't give any history of trauma, right?
Yes, ma'am.
Yeah. So from the CT, so before going to the MRI, what is your final impression?
It was a ruptured splenic abscess with extension anteriorly through gastrosplenic ligament into the posterior wall of the stomach and posteriorly into subdiaphragmatic area.
Okay, you can go to the MRI.
In MRI, it was T1 hypo, T2 hyperintense lesion, and with no sold areas, there was no blooming. And in diffusion weighted images, it shows diffusion restriction with more towards the peripheral area.
Okay. So from the diffusion, what's the impression?
So it could be seeing a diffusion restriction more towards the periphery. It could be etiology, could be a tubercular etiology, ma'am.
How can you tell it is tubercular etiology?
Because in pyogenic abscess, it will be more in the central of the diffusion restriction will be more towards the central. In tuberculosis, the peripheral enhancement, peripheral diffusion restriction is seen usually.
Okay, so now I'll ask you, like, how what is the imaging appearance in tuberculosis affecting the spleen?
It will be mainly of three type. It can be solitary, multinodular, or miliary TB, miliary nodules, and it will be in solitary. It will be heterogeneous lesion with internal enhancement, central necrosis, and or it can be.
What did you tell about that enhancement pattern?
Peripheral enhancement, then central necrosis, then heterogeneous appearance of the lesion. And it can, next appearance, it can be multinodular granuloma. Next is a miliary pattern, multiple small.
So out of what is more common?
Miliary pattern.
Yeah, most of the times you see multiple small nodular lesions in the spleen. Okay. So did you give contrast for this in MR?
MRI contrast not given, ma'am.
Okay. So what further information did you get from this MR?
We could narrow down the etiology to tuberculosis, ma'am, actually.
Tuberculosis. You can give us a DD because see again, and can you just show me the T2 and T1 once more? Okay. You don't have, you just have an image, right? You don't have the video, right?
No, ma'am.
Okay. So it was pure T2 hyperintense, right? Some
ma'am,
septations was there?
No, ma'am, no septations. It was pure T2 hyperintense lesion and T1 hypo, ma'am. There was no hyperintense.
But the wall of the lesion?
Lesion wall was not well, not seen, ma'am, actually.
Yeah, again here in the T1 you can see it's hypo in the center, but little hyper. So this was an area that was seen in CTS, little hyperdense.
Hyper. Okay, ma'am.
Yeah. So that again, and you're sure that it's not showing any enhancement, right?
No, ma'am.
Yeah. So it's some peripherally thick walled something, a cystic lesion. That's what your final impression.
Yes,
so what are the other factors here in the in the cross-sectional imaging, both in CT and MR, which actually helps you in diagnosing a inflammatory or infective pathology rather than a malignant etiology?
Guided aspiration can be done.
No. In the cross-sectional imaging. You said about that, but again, I'm asking you, what is that? What is the other point that favors this? So seeing the patient as a whole. So coming from the history up to here, you have all the investigations right now. So what is that? What are the points starting from the history that leads you an infectious or infective pathology rather than a malignant etiology?
So from the history, it was an immunocompromised patient with a high counts of 13,000 and elevated CRP.
Yes.
And in ultrasound, it was cystic lesion with internal echoes and peripheral vascularity, and with the rupture into the splenic hilum. Then in CT, it was a irregular walled lesion with extension anterior with the rupture of visceral surface and extending into the indenting into the posterior wall of the stomach. Then posteriorly, it is extending into the subdiaphragmatic space with adjacent reactive left pleural effusion. And in diffusion, incoming then MRA, it was T1 hyper, T2 hyperintense lesion with the diffusion restriction.
Yeah, so I just asked you, you told me the whole findings. So I asked you the key findings that help you in diagnosing the infectious pathology, not the whole findings. I just want points. You started with the history, very good. CRP, elevated count. Okay. The patient came with fever, immunocompromised patient. Correct. So these are the points that favors a infectious etiology. Okay. So coming to ultrasound, again, no internal vascularity within the lesion, more of a cystic internal echoes. CT, again, no enhancement. So no enhancement. So it's not of a solid lesion with necrosis. And the point I wanted you to tell that is associated pleural effusion and basal consolidation.
Yes, ma'am.
So that is always one point that you always see in the infectious bar inflammatory etiology. Yes, rather than we see is in disseminated malignancy, we do see ascites pleural effusion, but in a similar case, we often, because you have shown the subdiaphragmatic extension of the lesion. So the subdiaphragmatic extension of the lesion plus pleural effusion and basal consolidation always favor, most of the time favors infective. When you are asked questions in exam, the approach and how you come to the diagnosis is more important. You have to always start from the history. Okay. So so and again, how does the usual splenic abscess? What is the usual pattern and how does it progress?
Usually, it will be cystic lesion with internal. Internal in ultrasound, it will be cystic lesion.
No. The pattern of extension of the splenic abscess. See, one pattern you have seen. Actually, two patterns you have seen in this case.
Then multinodular.
No. It usually goes along the lesser resistance area. So usually it goes along the gastro. You already mentioned that.
Gastrosplenic ligament.
Yes, it always goes along the areas of least resistance and of course into the subdiaphragmatic area. Okay, so how do you identify the gastrosplenic ligament in CT?
By looking for the vessels, actually, then gastrosplenic ligament can be identified with the right and short gastric artery and left gastroepiploic vessel.
Proximal gastroepiploic.
Proximal gastroepiploic.
The main right and left gastroepiploic, which ligament comes there? What are the other gastric ligaments?
Gastric, splenic, hepatogastric, and
Yes.
hepatogastric is there. Then
Very good.
gastrocolic is there.
So gastrocolic ligament is identified by this. Rest of the gastroepiploid, left gastroepiploid and the right gastroepiploid vessels. Okay, so and always mention, you didn't actually mention the vessels, any of the vessels when you're describing the case. So always see that the vessels, you mentioned the vessels. Nita madam has also told that, especially the splenic hilum, because the lesion is extending into the splenic hilum, right?
Yes, ma'am.
Okay, any other DD for that? You were telling the abscess. Okay, agreed. Any other similar lesion coming here?
Next is the 60 generation of 60 generation of gastric lesion, ma'am.
Before that.
Gastric neoplasm.
Before that. Any other lesion which comes there? Again, very common that we see in our routine practice.
Pseudocyst, then hem.
Pseudocyst secondary to?
Secondary to in the pancreatic tail.
Pancreatitis. Because always most of the times we see this, right? The pseudocyst intending the posterior wall of stomach, and then it is extending into the spleen, which is very commonly seen. So the first you can give up first details splenic abscess, because we are not seeing the any evidence of pancreatitis. You correctly mentioned that when you were describing that. You should always mention that there's no pancreatitis in any splenic hilar lesion. So again, that's very common. That's why I wanted to point out that. So a splenic, a pseudocyst, a walled of necrosis, because maybe how do you differentiate an acute necrotic collection from a walled of necrosis? Or imaging wise, how do you differentiate a walled of necrosis from a pseudocyst?
Usually the presentation is after 4 weeks of starting of symptoms. Then it will be there will be internal heterogeneous, then low density, non-liquid density collection. And then there will not be no definite capsule and no peripheral enhancement.
You were telling about what? Pseudocyst, walled necrosis, or acute necrotic collection?
Acute necrotic collection, ma'am.
Okay. So see, out of these, what fits more in this cystic lesion? What fits more?
Acute necrotic.
Acute necrotic. This has a wall, right? This has a well-differentiated wall, right?
Yes,
well-defined.
Well-defined.
Well-defined wall, and there is no evidence of pancreatitis with a lot of debris.
No pancreatitis, ma'am. So
walled of necrosis. So you can definitely give a DD of a walled of necrosis because the pancreatitis is completely resolved, but there was a necrotic collection which has actually gone into the spleen. See, once it has gone into the spleen, it is actually difficult to resolve, right? So you can always give a DD of a walled of necrosis in this case, because all the thick walls, internal debris, everything actually comes to it. Okay.
Okay, ma'am.
Then you can give the differential diagnosis of what you said, the next DD.
Cystic degeneration of solid lesion from the arising from the gastric.
So again, what is the percentage? What do you feel? It is likely, unlikely?
Unlikely, ma'am, actually.
Yes. Why?
Because majority of the lesion, part of the lesion is within the spleen. Yes. Then and there is extension into subdiaphragmatic area.
Yes. Correct. So it's very unlikely, but definitely in the exam you can give that as a DD also, because it's closely abutting the wall. I mean, it is out of that, which tumor can present like this?
Just one is the gist, then duplication cyst, then
so you can't of a simple cyst like duplication cyst also, because it should be a complicated one. Any cyst means this appearance means it's a complicated, either with infection or with hemorrhage. Okay.
Okay, ma'am.
Yeah. Any other DD? Any other DD you thought of?
Then schwannoma, cystic degeneration of schwannoma.
Cystic degeneration of schwannoma is very, very rare, correct?
Then
Okay, no, only from the examination point for the discussion I'm asking you. Otherwise, this just looks like a splenic cyst. You can give this much of DD. Okay.
Okay, ma'am. Okay.
I think that's okay. I think like that approach is very important, as Nita ma'am told. And the way, starting from the patient history, all the important findings, and then finally reach the conclusion. And definitely you can give the DD like this, and you have to tell the examiner that this and this is very unlikely because of so and so reasons. So that's the pattern you should present in exam. Okay. That's it.
Okay.
Well done, Minju.
Thank you, ma'am.
Nita ma'am, anything more?
Thank you, Dr. Rashmi. That was very nice. Thank you for concluding that case. I will next call upon Dr. Sai to do the final case of the day.
Good evening, everyone. So, presenting the third case, a 61-year-old female who came with diffuse abdominal pain for 5 months, now presented with abdominal distension and vomiting. On clinical examination, the surgeons got sluggish bowel sounds. The lab parameters were within normal limits. The surgeons got an impression of clinical diagnosis of intestinal obstruction, and the patient was sent to radiology department for further evaluation. In our department, the X-ray abdomen supine and erect was taken, which showed centrally placed dilated bowels more than 3 centimeters, showing prominent alveolar conventus, and in the periphery we can see the collapsed bowel loops. And in the erect film, there are multiple dilated air loops, which are more than 3 centimeters in diameter and separated by 2.5 more than 2.5 centimeter. Then there is no evidence of intra or extramural air and no evidence of portal venous gas. Then there is no air under diaphragm, and the hernial orifices were normal. So from the X-ray, we came to a provisional diagnosis of partial high-grade distal small bowel obstruction. So we proceeded with a contrast-enhanced CT. The protocol adopted was no oral and rectal contrast were given. Since the bowel loops were dilated with fluids, then IV contrast 100 ml IOXL was given. Plain late artery line venous piece were taken. So the axial and coronal sections of shows a circumferential asymmetrical circumferential bowel wall thickening measuring about 10 mm, noted in the for a length of 10 centimeter, noted in the proximal ascending colon with shouldering and abrupt narrowing. There is loss of mural stratification in some areas with preservation of mural stratification in the rest of the areas. There was no ulcerations seen. This is associated with a dilatation of cecum with the which was identified by appendix, and the ileocecal junction was normal in position, and the distal ileal bowel loops were grossly dilated, and the ileocecal junction was identified with the presence of fat in the ileocecal valves. Then there was in axial images, we can see there is mild pericolonic fat stranding, and there is focal loss of fat plane with the right kidney. However, there is no indentation of the contour of the right. Then there were no other similar structures noted in the large bowel, rest of the large bowel and small bowel. Then there were no diverticulars or polyps seen. There was no any intramural or extramural air. There no air in the portal venous gas or air under diaphragm. Then the abdominal vessels were normal in caliber. No intraluminal filling defects, thrombus, or any aneurysm seen. Then there was no adjacent lymphadenopathy. Then there was no focal lesion seen in liver. In the spleen, there was a cystic fluid density lesion with a speck of calcification. We have done an ultrasound and showed a simple splenic cyst. In the right ileum, there was a lytic lesion with a sclerotic margin and a central sclerotic area, which is consistent with intraosseous lipoma. So, coming to the summary of the case, there was a focal asymmetrical bowel thickening in the proximal ascending colon with abrupt cutoff and shouldering. Then there is a loss of mural stratification in some areas. Then adjacent minimal pericolonic pathstanding was there. Then there was loss of fat plane with kidney, and there is no lymphadenopathy. By all these features, we consider the possibility of a malignant structure. Assuming malignancy, we gave a stage of T3, N0, and MX. The patient was immediately taken up for surgery, and the patient underwent right colectomy and ileostomy. The surgical findings were there was a structuring annular hard growth of ascending colon with cecal ballooning and grossly distended small bowel loops. This was the gross specimen of the obtained after the surgery. The HP report, histopathology report came as moderately differentiated adenocarcinoma.
Yeah, Dr. Sai, yes, thank you for the presentation. You have gone through from the clinic X-rays through the CT and finally with the histopath clinic, the surgical and histopath diagnosis as well. Can we go back to the X-rays? Right. Okay. So we have a supine and we have the rectum, right? Okay. So what is your idea of taking these? If you were given an option in a suspected intestinal obstruction to take just one view of the abdomen, which one would it be? You don't have the luxury of doing two. As I would say, you can just take one and maybe come to a diagnosis. Which one will you choose of these?
Erect will be taken.
Okay, well, I would disagree on that. Okay, on one course, what's the reason? I will tell you. See, you do get the diagnosis of intestinal obstruction from the supine or from the erect. Okay, so what is the additional point you tend to gain by doing the supine? Okay, you can look.
Distribution of the bowel loops can be.
So what does it? What does it? Yeah, so it gives you an idea of what.
If this is centrally located, it will be small bowels, and if the dilated loops are peripherally located, it will be of large bowel.
Okay, yeah, that thing can be made out even in the supine, erect and supine. So what I want to say is that when you have such a question, the answer would be to go ahead with a supine view, because it gives you not only the idea of which are the loops that are dilated, small and the large are dilated, and not only that, what you're going to see is the distal end. Can you look at your picture on the right where you are seeing the erect view? Below the level of the pelvis, you don't see anything, do you?
Yes.
It is a big haze when you take the erect, right?
Yes, ma'am.
Yes, am I right? Can you make that out, sir, Dr. Sir?
Yes.
It's a big haze below the level of the pelvic brim, whereas in a supine you can see all the iliac loops which are extending down. You'll be maybe able to see the rectal gas, all these things, because when you do the erect, the fluid tends to come down to all the lower part of the abdomen. So you don't have the idea of the distal, the loops in the lower part of the abdomen. So you gain much more if you're only doing a single X-ray. You gain much more by doing the supine obstruction. It also gives you an idea of the level of obstruction. Understand?
Yes,
The sigmoid loops are also dilated. Is your rectal gas is there? If the rectal gas is not there, what does it imply to you?
Dynamic obstruction.
In a bowel obstruction, you said it's a fairly high degree obstruction. So do you like to look at the presence or absence of gas in the rectum?
Yes,
and why?
Complete obstruction, there will be absent rectal gas. and in partial obstruction, we can,
And
in
yes, very good. The complete obstruction, it's not that a complete obstruction of a very few hours, it's you still may have, because you need to give a couple of days time for the complete obstruction, for the resorption of the gas from the rectum. Okay, so that is one thing. So all these things can be seen only when you do the supine. Okay, so that is answer for that. So when do you call a bowel dilated, the other small bowel?
If the caliber of the bowel is small bowel is more than 3 centimeter, we call it as dilated. For large bowel, if it is more than 6 centimeter, we call it as dilated. For cecum, it is more than 9 centimeter.
Very good. Right. So when you're doing a CT scan, is there any difference between you are giving oral contrast and all that? So your oral contrast, when you're very enthusiastic, when you give the oral contrast, you tend to dilate it even in normal, and even when you don't have obstruction, you may have some amount of, right?
Pardon?
When you give a CT, when you do a CT, any idea? Okay, doesn't matter. So okay, so this you are suspecting a low in small bowel obstruction, is it?
Yes, ma'am. From the X-ray,
Okay.
low.
Yeah. So what are the causes that you would think of? If you're from the X-ray, what are your differentials?
I see distal ileal obstruction.
Yeah, just give me your differentials. It's almost a complete obstruction. So what are the pathologies that you're thinking of?
Tuberculosis.
Yes, very good.
Then malignant strictures.
Of
terminal ileum.
Is that very common? That's not very common, right? I mean, like
ascending colon.
Yeah, that would be more common. Yeah. Okay, so you're thinking of benign and malignant causes, right? Yeah, benign and malignant causes, right? Do you think of ileus, a dynamic ileus in this case?
Because large bowels are collapsed and we can see the dilated small bowel.
Very good. So yeah, very good. So you're thinking more of obstructive, it's in the mechanical obstruction is there, right?
Yes.
Yeah. What does a string of beads sign mean to you if you are seeing that in a case of intestinal obstruction?
Pardon?
The string of beads sign.
The air trapped within the valvular convolutus.
Very good. So what does that imply to you? If you see that, what does it imply to you?
Obstruction, the time of obstruction is like chronic obstruction. The chronic obstruction, like not an acute one.
It implies very high grade of mechanical obstruction, okay, because it's predominantly filled with fluid and not air, because the fluid is almost completely filling it up, and you only have tiny bits of air which are trapped between the valvular convolutus. Okay, so that is what you mean by when you get this string of it definitely implies there's a mechanical obstruction and not any of your ileus and all that, because in those cases it's air which is more prominent. Okay. Yeah, when you have an ileus, it's more air that you see. Mechanical obstruction, you tend to get more of fluid, right? And that's why you get air fluid level as well. Okay, so let's move on to your CT. Can you turn on? Yeah, okay. So this is a short segment structure of the ascending colon, right?
Yes, ma'am.
Okay. And based on which features did you go ahead with malignancy?
Short segment,
very good. Yes.
Less than 10 centimeter. Then, then there is some areas showing loss of mural stratification.
Okay.
Then minimal pericolonic inflammatory changes. Presence of shouldering and
Shouldering, that would be one of the the abrupt transition point, the shouldering, short segment is a very clear transition zone is there, right?
Yes.
Yeah. And what are the types of carcinoma that you know of and I just want to ask you about one particular type because it differs in imaging a little bit from the other types. So what are the types of the CA that you know of, the histopathological types?
Adenocarcinoma.
Yeah.
Then
Mostly, yes.
colon.
Okay, yeah. Well, we have a small percentage of adenocarcinomas are the mucinous type. Okay, so I just want to ask you, is it possible at times to come to a radiological diagnosis of a mucinous adenocarcinoma from some particular imaging findings, which may make you think of the histopathological diagnosis of a mucinous adenocarcinoma?
Adenocarcinomas will be presenting as strictures.
Yeah, okay, that's fine. I'm just asking you if you have a mucinous variety, because there is a few particular imaging features which may make you think of this histopathological form. Do you know? Pardon?
Intramural cystic changes, calcifications.
Calcifications, I agree on that. Calcifications, you have very large masses, you get very large masses, which are quite hypodense, and they enhance very mildly, okay, because of the extensive mucinous content, they enhance quite mildly and quite large masses, and calcifications may be there in the primary. Also, if you have metastasis, those metastases also may have calcifications. Your hepatic metastasis may be either calcified or you may have cystic changes, in the metastasis. So when you see that, it's large mass, more than 50% of it is kind of cystic or maybe looking very hypodense, not enhancing much. That is what makes you think of maybe it's a mucinous type. Okay. So when you have mucinous type of neoplasms, what is the particular complication that can arise from them? Mucinous neoplasms?
Rupture of.
Yeah. If they rupture, what can it lead to?
Pseudomyxoma.
Very good. And what's the particular appearance of pseudomyxoma peritoneum when you do a CT scan? What makes you think that this is not ascites? This is most likely to be pseudomyxoma.
Scalloping of the.
Yeah, it kind of exerts a pressure. It gives you the typical scallop margins of the liver, and you have in malignant conditions which lead to pseudomyxoma peritoneum, you may have some a little bit of mild enhancing areas in the ascites. You don't have it in a simple ascites like when you have an ovarian CA. You don't have, because this is gelatinous stuff and it is not clear fluid, and that has malignant tissue inside in a malignancy, and that can give you kind of a heterogeneous kind of subtle enhancement as well in certain areas when the malignant type. So what is a benign condition that can give rise to pseudomyxoma peritoneum?
Mucocele of appendix.
Excellent. Right. So, okay. So that is some of the conditions. So I just want to ask you, other than malignancy, what are the other conditions which can give you stricture of the colon?
Inflammatory conditions, infective and inflammatory conditions. Then ischemia can cause strictures. Then
Okay.
Then radiation-induced strictures can be occur.
Okay.
Pseudomembranous colitis.
That does it.
Neutropenic.
What else? It is actually pseudostrictures. What are the conditions of pseudostrictures?
Pseudostrictures happens in colon normal spasm. Then sometimes colonic or volvulus can cause pseudostrictures. Then colonic
hernias. Right. Yeah. So how does what about another condition, diverticulitis? Can it give rise to stricture?
Yes, diverticulitis can cause strictures. It will be narrow segment.
Is it in the acute phase? Diverticulitis causes stricture in the acute phase, or after recurrent infections.
Recurrent infections can.
Yeah, and the acute phase usually does not cause an obstruction like that. Okay. So you said ischemia is one of the conditions which can give rise to colonic strictures. What are the usual sites of stricture secondary to ischemia?
Ischemia, the watershed areas like hepatic splenic flexure, and then rectosigmoid junction.
I'm sorry, which flexure?
Splenic flexure and rectosigmoid junction.
Very good. So splenic flexure is watershed between?
SMA and superior mesenteric.
What is the name of that point? Griffith's point, right? Okay. And the second one is rectosigmoid, otherwise called the Sudex point. Okay, that is the potential watershed between the sigmoid branches and the superior hemorrhoid. Yeah. Okay. So those are and in ischemia you have the other features of ischemia as well. You look for that. Diverticular disease, you have to look for which are the most common site involved by diverticular disease.
Sigmoid colon.
Yeah, sigmoid colon. Yes. And in acute diverticulitis, what is it that when you may have wall thickening? Yes, in your colon, you may have some mild narrow, you may have wall thickening, but what makes you really think this is diverticulitis and not neoplastic involvement? What aspect?
Disproportionate fat stranding.
Very good. It's a disproportionate fat stranding, which may with very minimal wall thickening when compared to the extent of the adjacent pericolonic fat stranding, which is one of the clinching factors which helps you. And of course, you can see the diverticle as well along with that. Right. So in your case, there is a lot of small bowel dilatation that is due to the incompetent IC valve, right?
Yes.
Yeah. So when you have a large bowel obstruction, your status of the small bowel, that depends upon the competency of the IC valve. And usually the right side strictures are the ones which are more likely to cause incompetence of the valve, like your case, right? Because if you have a sigmoid malignancy, you may not get that. So your case is called because it's usually associated with the right sided strictures, which will give you the incompetent, the IC valve, right? Okay. And this case, you said there are not many lymph nodes and not many adjacent, not much of fat stranding also. So it's a fairly confined and maybe a little early kind of disease, yeah. And so you can see it's a scirrhus type probably because there's not much of a mass. It's actually more of a scirrhus type of patient, right? Okay, and you want other causes pseudostricture is volvulus, right? Yeah. I just want you to just tell me about the volvulus that you know of.
Transverse.
So what is the most common volvulus?
Sigmoid valve.
Don't say transverse colon. This is one of the less common areas of volvulus. Okay. So, and what age group do you usually expect that in?
Old.
Yes. Yeah. Old and the debilitated. That's when you expect that. Yeah. Can you give me some the typical appearance and few things that will make you clinch the diagnosis? It's very, very simple. I have 2-3 things to just tell me.
Coffee bean X-ray, coffee bean appearance.
Yes. Okay, so usually you have two usually the say volvulus in the large bowel that's involved. So they are sigmoid and
cecal volvulus.
Yeah. So they cause this pseudostrictures. Okay. Yeah. So if you're doing a barium enema study in a case of sigmoid volvulus, what do you get?
Bird beak sign.
Yes. Yeah. The bird beak sign. Right. So do you know how many types of sigmoid volvulus are there? Okay. Yeah. You have the organoaxial or the mesenteric-axial. Okay, so that will give you a single loop or 2 transition points. What you say, the coffee bean, that's the closed loop type. That will give you because there are 2 loops. Okay. Or if it's simple twist and organoaxial, it will be 1 transition point. Whereas the usual, what you're saying is that coffee bean you have two transition points, right? Yeah. Okay, just because both will give you the bird beak when you put in the barium from below, because that stops. Okay. Whereas, but you can make that out only when you see that loop, how it's going, whether it's a closed loop type or a single transition point. That CT will help you in making a diagnosis. Okay. And how do you differentiate in a plain X-ray between sigmoid volvulus and a cecal volvulus? Okay, which one will give you hostration? Which one you will not see hostration?
Cecal, we will see hostration.
Okay, very good. Sigmoid, you will not see hostration. Yes. Yeah. Okay, and the waist of the volvulus will be towards the right side in cecal, and will be usually towards the left in sigmoid, right?
Yes.
Yeah, and the rest, because sigmoid is more distal, you will have associated dilatation of the rest of the colon is more likely to be there in sigmoid, right? Because cecal means you're unlikely to get the dilatation. Yeah, and then you have the northern hemisphere sign, and okay, where it protrudes, that can be variable. It's okay, but you have to have some idea about the differences between these two, because one of these is the pseudo strictures, right? The conditions which are pseudo strictures, right? So we dealt with ischemia, we dealt with infections, because we already dealt with all the features of infective strictures. In the previous case was inflammatory bowel disease, so I'm not going into that. We dealt with diverticular disease. Yeah, so that's it. I think we're already running short of time, way behind schedule. So yeah, I think we will close this particular case. Dr. Sai, well done. And all of you, all three of you have done very well in your descriptions and your presentation. I wish all of you the very best in your exams. I'm sure all of you are coming out with flying colors.
Thank you.
Thank you for giving this opportunity, Lali Madam and Rashmi.
Thank you, ma'am, again for the text.
It was wonderful. All the three cases were really beautiful. A different variety of cases which I saw now, and the students did very well. Thanks to Dr. Lali, your students pretty well. They answered every question, and the case also, the discussion went on very well with Dr. Gina.
Thank you, ma'am.
Thanks. All the best for you, the residents for the final year for their examination.
Thank you, ma'am.
I think Rashmi is not online.
Yeah, ma'am, I'm here.
You're there?
Yes, ma'am.
Yeah, you can thank them.
Yeah, so again, the residents, the three of them did well. I thank them for those selecting those three cases, which is typical exam cases. All the cases can come in exam, and thank you, Gina ma'am, Lali ma'am, and Neeta ma'am for that excellent case discussions. Almost, I think they covered almost all the points, and especially last case, Gina ma'am has actually included everything in column, everything that can be asked in the exam. So thank you, ma'am, Lali ma'am, and Neeta ma'am for that. And thank you, residents. Thank you, Gomadi ma'am, again for the backbone of our IRA Kerala. So again, the most enthusiastic person I have ever seen. So
I second that. I second that.
you are the role model. So we all follow you.
No, that's all because of you all. I have the support, that's why.
So thank you, ma'am. Thank you, Rejo sir, secretary. He is not there. And thank you, Venu sir. Usually he is there in almost all the sessions, but today, due to some reasons, he is not able to join. So thank you, Venu sir. And Demir sir, again another backbone who is actually coordinating the whole thing and everything. Like he's the man behind actually the academic sessions, the whole technical things he is actually taking care of. Thank you, Ramesh sir. And thank you, Soumya, the MedPiper team. Again, like she's been coordinating with me for this whole session. Thank you, Soumya. There was no technical glitches. Everything went on smoothly. Thank you, Soumya, for that. Again, thank you, attendees. All the residents have joined today. Please join us in the next session. We have Saturday another session by Dr. Usha on the mesenteric tumors and the mass-like lesions, which I think will be very useful for the residents. Please do join. And this month we'll be continuing gastrointestinal radiology. So thank you once again, all. For joining.
I would like to thank Dr. Rashmi because she's the one who has brought Trivandrum delegates together. I'm so happy to see all the Trivandrum delegates, and now she has got Usha from Trivandrum Medical College. So I am very happy to see the active participations because the enthusiasm by Dr. Reshmi. So I would like to thank her to bring all of them together.
Yeah,
Great job, Rashmi. I also feel the same. Yeah, great job.
Thank you, ma'am. Thank you, ma'am. It's all because everyone is cooperating. So that is one important thing, right? Okay, then.
Thank
so then we'll see next Saturday. So until then, thank you all.
Thank you.
We'll wind up the session.
Thank you.
Bye-bye.